I really appreciate the opportunity to be here. I think we're going to have fun with this course. And this is a fairly informal presentation, so feel free to stop me and ask questions. This is the outline of what I'd like to cover, talking about some of the tools that we have now and maybe some of the tools that are coming down the pipeline. And then we'll talk a little bit about microsurgery, endovascular treatment, patient selection, and go through some cases and maybe talk a little bit about the future. As everybody's aware, aneurysms are relatively common in the population. Probably about 2% of the population harbors aneurysms, but they're higher in certain populations like Asian and Finnish populations have a higher incidence. And of course, rupture of aneurysms produce subarachnoid hemorrhage. And as everybody's aware here, unfortunately, when an aneurysm ruptures, it causes significant, or there's significant potential for morbidity and mortality. Only probably about a quarter of patients who have a rupture that survive more than a month require completely, especially as more studies now are including cognitive outcomes, which I think are important and are lacking in some of the prior studies. There's almost 31,000 ruptures per year in the US. And although subarachnoid hemorrhage accounts for a minority of strokes, it has a disproportionate amount of disability because it tends to affect a younger population than the typical ischemic stroke. Looking back, and I haven't been doing this that long, but looking back, there's been a lot of advances, and I'll just briefly go through some of them. And on one hand, I think microsurgery has improved to some extent with modest incremental advances. Certainly, endovascular technology has advanced dramatically over the past couple decades. I think one of the important things that was critical in establishing endovascular as an option was actually the discovery of coils, or the implementation, the description and implementation of coils by Guglielmi and the UCLA group with the initial work published in the 1990s. And now, as everybody's aware, we have coils that are much better. Initially, we only had these, let me see if this has a pointer. Is there a pointer I could use? Or I can use this. Initially, we only had these helical coils here, but of course now we have complex shapes of coils and coils that have coatings on them, and they've advanced so far beyond the initial GDC coil developed in the 90s. I think another major advance, and I think this will be the subject of some subsequent talks, is that stent, especially stent technology, has advanced, and certainly balloon technology has advanced, and this has allowed us to treat aneurysms that previously weren't really feasibly treated with endovascular before. And the stents include sort of the typical aneurysm bridging neck stents, as well as the flow diverters, and that flow diversion will be a topic of subsequent discussion coming up. I think another thing that recently had FDA approval is the PulseRider device, which is designed as an aneurysm neck bridging device to provide scaffolding to treat wide neck bifurcation aneurysms. And I think has some promise. I think along those lines, targeting wide neck bifurcation aneurysms is the Webb device. And this is not approved yet, but I was recently, last month, on an FDA panel that looked at the application to approve this device in the US. So this is a endosaccular flow diverter, so it's deployed in the, within the sac of the aneurysm. And it's been used in Europe for a while with, I think, quite promising results. So I anticipate, but don't know, I think it'll be approved in the US probably later this year. And that will allow us to treat, or at least give us another option for treating wide neck bifurcation aneurysms, and may have some promise for subarachnoid hemorrhage when dual antiplatelet therapy may not be required for this because the device sits within the aneurysm sac itself. I alluded to this earlier. There's been some advances, I think, in microsurgical technique. I think many of us are trying to moved towards or have moved towards retractorless surgery. So this concept of heavy fixed retraction, I think, has been supplanted by gentler dynamic retraction with your suction, for instance. I think, and Drake did some of this work on tandem clipping, but this has really advanced different techniques for reconstructing complex aneurysms. And then I think bypass and flow diversion, I think Dr. Monteith is talking about bypass tomorrow. I think that's been important and still has some role in treatment of complex aneurysms. I'll just show this as an example of a case where this patient had a transfenoidal, had multiple transfenoidals, but came back, I think, about 2 weeks after her transfenoidal and had sudden massive epistaxis. And she has this pseudoaneurysm shown here from a carotid injury. Why it developed or manifested in delayed fashion, I'm not sure. But this was an isolated hemisphere, so we did a test balloon occlusion, and she became aphasic and hemiplegic within seconds. So this case was treated some time ago, and at that time, we basically trapped that pseudoaneurysm. A pseudoaneurysm is a false aneurysm, and it has a high propensity to rebleed. So this is a radial artery bypass from the external carotid to M2 branch. And looking back at this, and I hope I can share at least how things have changed in my mind, how we treat things over time, because this is not the way I would think about this problem now. And it gets back to, we have microsurgical tools, and certainly we can do these bypasses. And if you go to conferences, you'll see some people still fixated on treating cavernous aneurysms with trapping and bypass. But in my mind, that this is something that we would treat in 2018 with flow diversion for patients with isolated hemispheres, et cetera, if possible. And this was a case that we reported back in 2012, but this patient, similar story, but she had a FES procedure, and they injured the carotid during that procedure, and we treated it with a single pipeline device. And this endoluminal reconstruction strategy, and there's been a lot of reports on this now. This is, I think, done a pretty good job of treating some of these pseudoaneurysms resulting from iatrogenic vascular injury. And I think this goes along with the basic concept that things within the endovascular realm have advanced so much over time. So I think that in general, we've seen a paradigm shift towards endovascular therapy. And I just wanted to take a minute or two to discuss a couple of studies that have really shaped how we think about treatment, particularly of ruptured aneurysms. And I hope to outline some of the controversies still that remain regarding treatment of ruptured aneurysms. So the ISAT study initially was published in Lancet in 2002. And over time, there's been a number of updates, including the long-term follow-up data in 2015 published in Lancet. But as this audience is aware, this was an international prospective randomized trial comparing clipping with coiling for acutely ruptured aneurysms. And the important part about this, because this will be distinguished when we talk about the Barrow Ruptured Aneurysm Trial, patients had to be deemed eligible for either treatment. So at least when this study was conducted, not all aneurysms, of course, were deemed suitable, at least at that time, for treatment with endovascular means. So only about a fifth of patients who were actually screened were enrolled in this study. So it's a very selected group of patients. And what this study wanted to define as their endpoint was the percentage of patients who are dead or dependent at 1 year. And they also looked at rebleeding from the treated aneurysm and risk of seizures. This was a large study. Ultimately, about 2,100 patients were enrolled. And the main message from this study that emanated throughout the neurovascular community is that patients who are coiled did better. So 23.5% of patients were dead or dependent at 1 year compared to about 31% in the clip patients. And And I'm summarizing here, this was extended in follow-up to 10 years, and even at the 10-year follow-up, the probability of disability-free survival was still higher in the coiled group at 10 years. Not surprisingly, the risk of epilepsy was lower in the coiled group. And one of the things that was reported, there was a neuropsychological sub-study of ISAT, and it found that cognitive outcomes were better in coiled compared to clip patients. And this was the first time that a neurocognitive study was applied to a randomized cohort of patients, and it showed that the neuropsychological outcomes were better in the coiled patients. But to summarize this, ISAT clearly was an important study. It was well conducted, but as we discussed, it applies to a specific population of patients who are deemed suitable for treatment with either endovascular or microsurgical clipping. How this fits into everyday practice, I think it's still a matter of discussion, but there's no doubt this was a critical study that helped to shape practice throughout the world. The other study that I wanted to just briefly talk about is the BRAT study, or the Barrow Ruptured Aneurysm Trial. And this was very different. And this was a diagram that I borrowed from an editorial comment from Tim Darceau and Jean Raymond. But basically, ISAT was a classical randomized controlled trial shown here. So patients were verified at screening that they were eligible for both options. They were randomized, they received their treatment, and there was few crossovers because, for example, in the ISAT, they had to be eligible for each treatment, and then the study was analyzed. Well, BRAT was different. What BRAT wanted to do was take a series of patients and randomize them at outset, so upon presentation, and they did that by, I believe, by the call schedule. So on one day it was microsurgery clipping, on the next day it was endovascular. And what this tried to do was get as many patients in the study as possible, so not to pre-select up front. The caveat being that because you did it that way, that there would be more frequent crossovers. So for example, if a patient came in on an endovascular day and the endovascular specialist, and at Barrow they were very talented, if they didn't think that it could be done, it would cross over to clipping. And we'll talk about how that's a problem, because those patients essentially aren't randomized at that point. They're then assigned to clipping. But so it's just very different study designs, but this was supposed to be an all-inclusive study, the BRAT. And so 725 patients were screened, and 500 eligible patients were enrolled. And 238 patients were assigned to clipping and 233 to coiling. And as I mentioned, crossover was allowed, but it was an intent to treat analysis, so the primary outcome analysis was based on initial treatment modality assignment. And there was standardized post-care treatment, and they wanted to look at death or dependency at 1 year, similar to ISAT. And they wanted to look at aneurysm occlusion, rebleeding rate, et cetera. And so ultimately what happened, and this is the flow diagram of patient enrollment, 62% of patients assigned to coiling actually receive coiling, so you can get a feel for the crossover rate. So this is a busy slide, but basically it had similar results, at least at 1 year, compared to the ISAT trial. So 23% in the coil group who were assigned to coil group were dead or dependent at 1 year, compared to 34% in the clip group. And then when looking at a multivariate analysis predicting of prognostic factors associated with poor outcome, clipping was associated with poor outcome, at least at 1 year. So the authors concluded that poor outcome was higher in the clip compared to the coil group, and the policy of intent to treat favored coiling, resulting in fewer poor outcomes. And of course, acknowledging the more frequent crossover of coiling to clipping. And they concluded at this time point that high quality surgical clipping must be available as an alternative modality. They published the 3-year outcome data, and the risk of poor outcome in patients assigned to clip versus coil had decreased and was no longer statistically significant. And there was still a difference in posterior circulation aneurysms, and I'll discuss this a little bit more tomorrow when we discuss pica aneurysms. So at this point, the difference had narrowed. And then this hasn't been published yet, but it's going to come out in Journal of Neurosurgery shortly. The 10-year Barrow Ruptured Aneurysm Trial data will be published. They limited this analysis to saccular aneurysms. Initially, they included angionegative subarachnoid hemorrhage, fusiform aneurysms, dissecting aneurysms, but this analysis that will come out was limited to saccular aneurysms. And what they found was that there was no statistically significant difference in poor outcome between the groups at 10 years. And 36% of the coiled patients had crossed over to clipping. The retreatment rate, I think in keeping with the literature, was not unexpectedly higher in the coiled compared to the clip group, 20% at 10 years versus 0.8% in the clipping group. There was 2 rebleeds in the coiled group within that follow-up. One was from a previously coiled target aneurysm, and another was from an unruptured aneurysm that was coiled. But overall, still the rebleed rate was low in the coiled group, but higher compared to the clip group. Sort of in summary, the BRAT study was an important study that I think has shed more light on treatment of ruptured aneurysms. We discussed the high crossover rate being a limitation. And the important thing to note is that BRAT was done, patients were enrolled between 2003 and 2007, and the technology has changed a lot since then. So I think if you look at a contemporary series, the crossover rate would be even lower compared to back during that time. And then as these patients were followed out longer, the number of patients available for follow-up decreased because patients were lost to follow-up or died for other causes. And so it's likely that it was underpowered to detect differences, especially at the 10-year follow-up point. But this is something that should also be considered in counseling patients and their families with ruptured aneurysms. Sort of the impact of ISAT, this is based on not great data, discharge data from the nationwide inpatient sample. But you can see, and this is just looking at patients who are treated with coiling versus clipping. The amount of aneurysms treated with coiling in the US has increased dramatically, beginning at the initial publication of ISAT over time. And I think the European experience is similar to that. And in Europe, I think even fewer aneurysms are clipped now compared to in the US. So looking at this decision to clip or coil, I think that, you know, we have to keep in sight the overall treatment goal. It's to use, to provide the safest, most effective and durable treatment that could be applied with the lowest associated risk. And so it's not so much clipping versus coiling. It's using these different tools to treat the same condition, so whatever is best for the patient. Sometimes we have to use both, as we'll discuss. It's really using all these treatment modalities versus the aneurysm is the competition. So as everybody's aware, microsurgery has been around for a long time. It's durable, it's effective. We have long-term data demonstrating that completely obliterated aneurysms with clipping have a low incidence, extremely low incidence of recurrence and rebleeding if it was a ruptured aneurysm. The limitations are well known. It is more invasive, although people have moved more and more towards keyhole craniotomies and less invasive approaches. There's some element of brain retraction. Even if we're not using fixed retractors, it's still difficult to access certain locations, particularly the posterior circulation. Perforator injury, because we're working exovascular, the perforators come into play, which are less an issue with endovascular. Cranial nerve injury is still an issue, particularly at certain locations such as the basilar bifurcation. Endovascular treatment, the options that we'll really briefly discuss are coil embolization with or without balloon or stent assistance. Flow diversion will be discussed in a subsequent talk. Liquid embolic agents, we don't really use Onyx HT500 anymore, which was a agent we used in the past, but sometimes we will use liquid embolic agents for distal aneurysms to occlude the vessel as well as the aneurysm, but we won't spend much time talking about that. Endovascular is obviously less invasive, a more rapid recovery, excellent safety profile. With, I think, more and more the efficacy has been established. Durability, like in the BRAT study, the incidence of recanalization, coil compaction requiring retreatment is higher compared to clipping. Wide-necked aneurysms remain difficult at times, but I think some of the technology coming and the use of, for example, Y stenting hold promise. MCA aneurysms, or where aneurysms incorporate a vessel into the aneurysm itself, are more difficult potentially to treat endovascular, and giant aneurysms, although in all fairness, giant aneurysms are difficult to treat with both microsurgery and endovascular. So I think that if we look at patient selection, there's patient-specific factors, age, clinical grade, comorbidities, and life expectancy play into the equation. Aneurysm-specific factors, so size, location, neck width, dome to neck ratio, presence of calcification, presence of thrombus within the aneurysm, incorporation of vessels into the aneurysm, or multiple aneurysms all come into play in this selection process. And I think more and more in 2018, patients and or their families have specific expectations or desires when we counsel them about treatment options. So I think some generalities, I would say at many and most centers that basilar bifurcation and a majority of posterior circulation aneurysms are treated endovascularly. I think in the US that middle cerebral artery aneurysms are treated more frequently with microsurgery, but as I mentioned with some of the technology coming, that may shift over time. And then other aneurysms are decided upon on a case-by-case basis, probably with coil embolization preferentially recommended for ruptured aneurysms suitable for either method. One note, and I think that this has been the subject of some studies, but ruptured aneurysms that we're planning to do stenting for require dual antiplatelet therapy. And as this audience is aware, with patients with EVDs requiring shunting and on dual antiplatelet therapy can pose some challenge with an increased risk of hemorrhagic complications. I think that safety in doing dual antiplatelet therapy in the setting of acute subarachnoid hemorrhages demonstrates an acceptable safety profile. I think that there's some exciting things coming. There's modified stents that are less thrombogenic. Pipeline has a modified device called Shield, which has a phosphorylcholine coating that's covalently linked to the stent itself, and that may decrease thrombogenicity. And maybe coated stents that deliver anti-aggregation medication will come into play. None of them are approved yet, but that's coming. That will eliminate potentially the need for dual antiplatelet therapy. And as I mentioned, some of the endosaccular flow diverters, where you can deploy the device completely within the aneurysm, may not require dual antiplatelet therapy. Moving on to some case examples and discussion. This was a patient, 54 years old, presented with acute subarachnoid hemorrhage and has this intercommunicating artery aneurysm that it's a little hard to see because of the lighting, but it has multiple lobules, but it's higher in the vertical dimension compared to the sagittal or coronal dimension. And this is something that with standard coils, no adjunct can be treated effectively. And it just speaks to the design of coils now compared to when we only had helical coils. This is a patient that had presented with a seizure while he was working on the golf course, 18 years old, They did a scan, showed this, which appears to be a giant aneurysm with some peripheral calcification and probably some thrombus within it, and has this aneurysm here, and this is the 3D reconstruction, but fairly broad-necked. At the time when this was treated, the patient was adamantly opposed to surgery because he's a young patient, the size of the aneurysm, the lifelong likelihood of rupture, that this should be treated, I think. But he was adamantly opposed to surgery, and at that time, we didn't have flow diverters, so we treated this with stent-assisted coil embolization. And I think now that this could be treated effectively, potentially with a flow diverter and some coils, I think it would be challenging for surgery, but could be handled with surgery as well. But the patient, basically refused surgery, and his family. This is likely to recur over time. But I think that an endosaccular option with a flow diverter would provide durable results. This can be a challenge now, wide neck basilar bifurcation aneurysms, particularly when they're ruptured. When I was a resident, we used to operate on all the basilar aneurysms, and of course that shifted over time. This can be treated in a number of ways, and I show this case to illustrate how good stent technology is. So one of the ways this can be treated is with one stent that goes out the PCA and comes down, and you can kind of push the stent up and question mark it, or it could be treated with Y stents. But I think at this time, we wanted to see if we could lay a stent across the PCAs, which would reconstruct and completely cover the neck. And this just shows how good the microcatheter technology, navigating back from the carotid to the PCA, through the PCOM, and then across, and laying the stent in and coiling it. And so the stent technology over generations has advanced tremendously, and we can navigate stents to most places that we want it. But looking at this is probably a good case for, an endosaccular flow diverter, especially in the ruptured setting if we don't have to use dual antiplatelet therapy when those become available in the U.S. This is something we may talk more about as this course progresses, but these blister aneurysms, I think we've gone through, I would say, a paradigm shift over time. We used to operate on a lot of these, and I think some people still do. I think that I've tried most treatment options, so clipping, clip wrapping, trapping with bypass, with or without bypass. And these are, if you see an aneurysm, I guess this is a point to illustrate. So this arises on the opposite side. I would say we could call this a ventral, or you could call it dorsal, depending on what you're looking at it. But it originates on the side opposite the choroidal and the posterior communicating artery, so aneurysms generally don't occur there. And this is sort of a dissection in the vessel. It's not a true aneurysm. So I think that many of us now would probably consider flow diversion as a means to treat this with endoluminal reconstruction, although people still operate on these. But I think that there's at least been some shift in thinking as to how these are treated, because these are not a typical aneurysm. When you go in and operate on them, you identify the carotid, there's usually some clot on it, the clot comes off and the aneurysm ruptures, and you're looking at the inside of the carotid artery because it's not a true aneurysm. It's a pseudoaneurysm. I think another area where endovascular treatment can be a very attractive option is in a patient who's had a prior craniotomy and clipping. So this patient had an ACOM aneurysm that was treated. You can see the clip here on the CTA and the clip here, and there's this recurrence here. And certainly we can go back in and clip the aneurysm, but you're dealing with scar and so forth. And this can be effectively dealt with endovascularly, not having to deal with the effects and sequelae of the prior surgery. I think that we talked about how MCA aneurysms are frequently treated with microsurgery, and we can effectively reconstruct a bifurcation with surgery. But this was a patient, we have to take patient-specific factors, as we mentioned earlier, into consideration. This was a patient who came in with severe neurogenic stunned myocardium and had congestive heart failure and was very sick on pressors. And as we discussed, typically we think of these as being treated with microsurgery, but we used a balloon in this case, and I quote Dr. Jain, who was my mentor, and he was quoting W.H. Auden, prohibit sharply the rehearsed response, meaning that just because it's an MCA aneurysm doesn't always mean surgery. And so this was a pretty good solution for a sick patient who probably couldn't undergo open surgery, at least with not significant risk of medical complications. So roles for microsurgery in my mind in 2018 are complex aneurysms that are wide-necked, involving branches at the base, requiring multiple clip reconstruction or bypass. I think ruptured aneurysms with hematoma, and we could argue back and forth about this. In my mind, a patient with a big hematoma coming from an aneurysm, we can clip the aneurysm, take care of the hematoma at one time. But I can tell you when I was in Philadelphia, some of my partners would coil the aneurysm and then go straight up to the OR and do a decompressive hemicrania and take care of the clot after the aneurysm was coiled, or do it all in a hybrid room. I think patients who have multiple endovascular failures are a potential case for microsurgery, particularly if there's not a good endovascular retreatment strategy. Potentially young patients with the thinking being that microsurgery is durable for the rest of a patient's life. I think unruptured aneurysms in certain cases, that's debatable again with the durability and lower rate of retreatment, and of course, as we discussed, patient treatment with one of the examples I showed earlier as well. Patients sometimes, and often come these days to your office with fixed notion in their mind as to how they want the aneurysm treated, and they've done a lot of research, and you may be a second or third opinion, and so that's something that goes into it. Some patients, believe it or not, will strongly want their aneurysm clipped because they don't want to worry about prolonged follow-up or the chance of recurrence, et cetera. So I think there's a pretty good example of a patient in their 50s who came in to the ER and blew their pupil while they're in the ER and has a big clot, and you get a CTA and it shows an aneurysm that you can see the ruptured teat here extending into the hematoma. So in my mind, this is a good case to go straight to the ER, take the bone off, subtotally evacuate the clot, and then clip the aneurysm and maybe finish taking out the clot. I think that that's a good role for microsurgery. I think I'll just briefly show this case, but sometimes it's not clear what the right option is. There's a younger patient who came in with headache, dysphagia and right-sided weakness, which subsequently improved. He had tiny perforator infarcts in the left hemisphere, but has sort of a giant with some fusiform aspect to it, some thrombus located within it. And then this is the angiogram where there's vessel going in and then a couple of vessels going out, one down here, one up there, and it's not clear where the vessels come out at very different spots, and I didn't think that there was a good endovascular option for this, and I wasn't sure that there was a good microsurgical option for this, so we thought about this and decided to basically reroute flow, the idea being that we could do a proximal occlusion here after doing a distal bypass and hope the aneurysm thrombosed over, or maybe come up afterwards through the bypass and coil any remnant that was needed to be treated. And I'll just show this video. This is at the time of surgery, and what's interesting here is that this is a cortical MCA vessel on this guy's cortical surface. It's huge, probably about 3 millimeters, and it's atherosclerotic. And I'll just play a short excerpt from this. This is just dissecting the cortical branch and then opening the sylvian fissure. And what was interesting, here's the aneurysm way down here in the depth, and I made no attempt to expose the aneurysm. I just wanted to expose M1 going into it. And so here's M1 just before going into it, and then this is a radial artery, and this is actually a cortical vessel that's about 2 millimeters in diameter. I tried to sew it initially into this vessel. There's actually a suture here, but this was so hard and atherosclerotic that the clips wouldn't close it temporarily, so I had to suture that up and go distally. And then this was the external carotid. But what happened in the end was that this is the proximal occlusion. The lenticular striate seemed to be filling still. Of course, that was a risk with the surgery. We couldn't see all of the lenticular striates, at least distal to where it entered the aneurysm. Radial artery bypass, and the aneurysm thrombosed pretty quickly. And the last time I had seen the patient, he was doing really well, but there was starting to be an aneurysm forming at this anastomosis site. It had dilated. And so how that will shape out in the future, I'm not sure. This was a young guy with no vascular risk factors either, and why he had this extensive atherosclerosis is unclear. Another thing I wanted to just briefly mention is that large and giant paraclinoid aneurysms, I think, presenting with visual loss are a problem because an endovascular treatment, at least placing some coils in it, can temporarily increase mass effect. And so from a visual outcomes perspective, I think it's not entirely clear what's the best thing to do. Surgery carries risk of visual loss as well with manipulation of the nerve. So certainly we can stent coil or coil aneurysms like this, and I think flow diversion, as I'll mention in a moment, has a role. This was a patient who had presented with, initially thought to have a pituitary tumor, and thank goodness it wasn't operated on, but had this massive or large supraapophyseal aneurysm causing chiasm compression. And this was a patient who actually strongly wanted surgery, so we clipped the aneurysm by using multiple fenestrated clips, doing retrograde suction decompression, where you clip distal to the aneurysm and suck back to deflate it, and then put multiple clips stacking them on it. And her vision actually improved following surgery, although could have declined from nerve manipulation. And I think that this will be discussed later, but flow diversion, I think, for those aneurysms holds promise. I think for cavernous aneurysms, I alluded to this earlier, but I think there's little role for microsurgery or bypass in 2018. And I've known Salim Abdurraf, who for a long time, and he still advocates for trapping and bypass of certain aneurysms like this, but I think that this can be potentially effective treated with flow diversion in 2018, and I think that we've moved away from trapping or proximal occlusion with or without bypass. I think for time's sake, I'm just going to skip through this case. That was a case where we did both endovascular and open surgery. This was a patient who had subarachnoid hemorrhage, and it was diffuse, and we weren't sure which aneurysm had ruptured, and they have a basilar bifurcation aneurysm here and a pica aneurysm down here, which was fairly broad-necked. And it was probably the basilar aneurysm actually that ruptured, so we coiled that, and we ended up taking the patient to the OR and clipping the pica aneurysm because we weren't certain about preserving a large pica. So both treatment options can be used in a single patient potentially effectively, but we'll talk more about pica aneurysms tomorrow. I wanted, just in the last closing minutes, I wanted to discuss some questions that remain regarding how aneurysms behave. This was a patient I saw in Philadelphia, had a subtle subarachnoid hemorrhage here and had this PCOM aneurysm that was coiled. And on the other side had this MCA aneurysm here and this anterior choroidal aneurysm here, and was lost to follow-up, and then came back 5 years later with a new subarachnoid hemorrhage And what was interesting is that this patient maybe in retrospect had this tiny bump at the carotid bifurcation, and now 5 years later presented with a rupture. But the rules that we had suggested that the other larger aneurysms on the other side, if anything, should have resulted in subarachnoid hemorrhage. So I think we need to know more about the biology of aneurysms to facilitate patient selection and to develop novel therapies. And just a word on training the next generation of vascular neurosurgeons. And we've written an article on this, and it's been the subject of a number of discussions, but resident duty hours have been reduced throughout the world. I don't know what it is in UK. It's 44 hours or 54 hours. Here it's 80 hours. And I think there's good reasons to restrict the duty hours, but the fact is that we have less time available for potential cases. And concomitant with that is the number, absolute and relative proportions of open aneurysm surgeries has certainly decreased. And now the aneurysms that do go to the OR tend to be more complex. And how do we train the next generation to be facile? I think one of the things, there's some data and a push toward concentrating aneurysm treatment at larger centers. And there's some data about outcome being associated with higher volume, improved outcome with higher volume centers. I think maximizing educational experience afforded by open aneurysm surgeries, so preparing for the cases, discussing it ahead of time. I think that simulation, microvascular laboratory training, doing 3D printing of the aneurysm that you're going to treat and going through that, or virtual reality, I think will help to maximize the educational opportunity afforded by each aneurysm clipping. And then I think fellowship training will be essential. And I'll just close with this case. This patient came to the ER with severe headaches and has this fairly broad-necked carotid bifurcation aneurysm pointing superiorly. And one interesting thing is that I wanted to know what the status of the anterior communicating artery was. And so I did a carotid cross-compression where I injected one side and compressing the other to see the cross-fill, and there was a small amount of cross-fill that I saw. So one strategy would be MCA has to be preserved, but maybe the aneurysm and ACA could be occluded together and it would fill from the other side, but that looks suboptimal on the study. So we took the patient to the OR, clipped the aneurysm. No matter what I could do, I couldn't get the ACA to stay open, and I think probably what happened is that some clot or something went into the A1 origin. This is the intra-op angiogram. Aneurysm is clipped, MCA is open, and I shot the other side, and both ACAs seem to fill, and this is A1 back to the clip. The patient did well initially. On post-op day 1, was discharged from the ICU. Post-op day 2, though, became weak while in the bathroom, became hemiplegic on the left side, got a scan, and there's a caudate infarct also near the capsule, and then started to get an anterior cerebral artery infarct that progressed to the whole ACA territory on the right side. And I think in retrospect, probably what I needed to do, knowing that the anterior communicating artery was small, was that I probably needed to open the aneurysm and see if I could extract the clot, maybe that was at the A1 origin, or do something to make sure there was antegrade flow through, because I knew that the anterior communicating artery aneurysm was small. The anterior communicating artery was small, but this patient was devastated by this stroke. And the patient had headaches, but this was an unruptured aneurysm. So being from Canada, Dr. Drake was one of my heroes, and he published a book on experience with 1,767 patients with vertebrobasilar aneurysms that he operated on. And in the start of the book, on the inside cover, he wrote, "If only we could have back again many of those who were lost or badly hurt for a second chance in the operating room, or it could be endovascular suite in 2018 with what we have learned." So I think one message I wanted to pass on is it's important to learn from our errors, learn from our complications, to do everything we can to prevent them from occurring again. So in summary, cerebral aneurysms remain a devastating disease. I think our understanding of aneurysms has evolved, although much work is left to be done to help improve patient care outcomes. Endovascular therapy is a safe and effective method for treatment of acutely ruptured, as well as many unruptured aneurysms. I think microsurgery remains an important option in the treatment of aneurysms and will remain essential for the future. And well-trained vascular neurosurgeons are needed for the patients of tomorrow. And I think, and this is what I think your generation is tasked with, we need to push the bar higher. We need to do better for patients. I think we can develop treatments, medical treatments for patients, novel, non-invasive or minimally invasive treatments for patients, but that will be the tasks that you all are faced with for the future. So I'll stop there and I'll take any questions. Thank you.